Morphology is the cornerstone of the diagnosis of MDS. Whatever I speak in the next couple of minutes is complementary, supplementary, ancillary, whatever adjectives you may use. Yesterday, all along the whole day, NGS, NGS, NGS. So it has become a fad. Whenever a new technology comes, we call it a disruptive technology. And NGS came with the name of a disruptive technology, but now I think it is gradually gaining ground, but we must use it at the right time, at the right place, in the right patient. That is what is most important. With that background, I bring greetings from my hospital in Calcutta. I'm sure Professor Young has already visited us during his last visit. I will not go into these because any talk on myelodysplasia is incomplete until unless you introduce dysplasia to the audience. So already she has done a great job in doing it. So I will skip this slide. As you all know that you can have unilineage and multilineage dysplasias in all the three cell lineages. And cytopenia is the hallmark of the peripheral blood. And most of the patients, when they progress over a period of years, progress into acute myeloid leukemia. Predominantly in the West, they are a disease of the 7th or the 8th decade of life. But in India, as in any other hematological disease, we are a decade or a decade and a half earlier than the Western population. And I want to highlight that diagnosis of myelodysplasia is a joint effort of the clinician, pathologist, hematopathologist. So it's not a single person's diagnosis. You have to work in tandem to arrive at a diagnosis of myelodysplastic syndrome. This is a summary slide of the last MDS 2016 classification of the Blue Book of WHO. The last entity, I have highlighted it yesterday through a question, refractory cytopenia of childhood, is a provisional entity. It was in 2008. It remains as a provisional entity in 2016. And I think a lot of debate has happened yesterday on this topic. If you come to the molecular pathogenesis of myelodysplasia, we all know that it is a complex pathogenesis because of the high rate of genomic heterogeneity. Large number of driver-associated mutations have been attributed to myelodysplasia. So when you have a genetic complexity in myelodysplasia and it affects the hematopoietic stem cells, your bone marrow milieu changes, and it also gets compounded by many of these extrinsic factors that we have in our day-to-day life. And that gives rise to the genomic mutations which affect the diverse pathways in the form of either RNA splicing defect, epigenetics, transcription, signaling, and metabolic pathways which are all affected. And commonly, myelodysplasia happens due to somatic mutations, many chromosomal abnormalities, and less often due to germline mutations, which we'll see in the next subsequent slides. Here, I would just like to say that chromosomal abnormalities came earlier than the molecular abnormalities, and we looked for myelodysplastic changes through these karyotypic abnormalities in the form of karyotyping, FISH, SNP arrays, and now you have array CGH. And I think the karyotyping is soon going to be replaced by the high density arrays because you don't have to grow the cells, it's just DNA based, and the information is huge in terms of copy number variations, in terms of uniparental disomies, in terms of copy neutral uniparental disomies, and a lot of these things will be gradually coming into most of the laboratories. So when you look at the cytogenetic abnormalities, I'll just, for completion's sake of the molecular aspects of MDS, you know that you have some MDS defining cytogenetic abnormalities. She has already mentioned some of them. And you have some common cytogenetic alterations that you find in myelodysplasia. So karyotyping, fish is a must in myelodysplasia. This is a table which summarizes the different chromosomal abnormalities. We discussed at length about monosomy 7 yesterday. So you have del5q's, trisomies, you have Y chromosome loss, deletion of certain chromosomes, good, bad, and the ugly, which has already been dealt with by her. So we have a ICMR consensus document now for the management of MDS. I was the chair of this committee and Dr. Biju was a member. And we have the ICMR site has published this. And here we have made minimum recommendation of the for the Indian laboratories and medical centers. We must do karyotyping, 20 GIMSA-banded metaphages, detection of MDS-associated abnormalities, and we must do fish analysis at least for chromosome 5, 7, 8, and 20. So coming to the molecular basis of myelodysplasia, we know that in myelodysplasia, you have ineffective erythropoiesis. So undergraduates define it as peripheral blood cytopenia in the face of an hypercellular bone marrow. That's because of an increased apoptosis. And there is an impairment in the differentiation and maturation of hematopoietic stem cells. And down the line, you have emergence of neoplastic clones with dysplastic features, and they have a proliferative advantage. Yesterday, we discussed about the presence of multiple clones in the bone marrow. Not necessarily they are neoplastic. Neoplastic clones gradually accumulate over a period of years, and they acquire genetic defects. And these clones proliferate in the marrow in advanced forms of MDS, and finally they transform into acute myeloid leukemias. So this is a snapshot of the entire process that happens, the molecular pathogenesis of myelodysplasia, starting from the signal transduction defects through the receptor tyrosine kinase pathway, where you can have FLT3, KIT mutations also being seen gradually more and more in MDS. Then you have the cohesin complex abnormalities where the HRR genes are involved, like SMC3, 1, and RAT21. Then when you move on to the splicing mechanism mutations, you have the SF3B1, SRFSF2, UTAF1, and ZRSR2. These are all RNA or DNA splicing site defects. And when you have the DNA transcription abnormalities, you have the RUNX1 and the TP53 being involved. And when it comes to DNA methylation, as part of the epigenetic process, you have the DNMT3A and the TET2 being involved in a large patients of myelodysplasia. I will come to the specific red starred mutations because they are the ones who are important in MDS. So if you see the clonal architecture of MDS and its progression to acute myeloid leukemia, you will find that a normal hematopoietic cells acquires some founding mutations like the RNA splicing mutation, the DNA methylation mutations, and then it forms an abnormal clone, and that clone survives in the marrow, and then they become subclones, various types of subclones, and one of the subclones could proliferate to give rise to myelodysplasia and ineffective erythropoiesis. So this is a slide which will tell you as to what are the common mutations that are seen in various morphologic types of myelodysplasia. She has already shown it. So I am not going to take more time on it, but all that I want to highlight is all the different types of morphologic entities have been described. And you can see that TET2, SF3B1, SLX1, SRSF2 are the DNMT3A are the 5 commonest mutations that are seen in most of the morphologic entities of MDS. So somatic mutation that you see normally in MDS that happens in the point mutations, and as the disease progresses, accumulation of more point mutations happen. And when you look at the cytogenetics, nearly half of the patients of MDS will have some kind of cytogenetic abnormality. And when you look at the molecular genetics, almost 90% of the patients of myelodysplasia will have some sort of genetic abnormality, which you need to look at by various modalities of techniques available in your laboratory. So more than 45 to 50 recurrently mutated pathogenic mutations, somatic mutations have been detected and identified, and more are being added gradually as more and more patients are being looked at in the discovery mode. So coming to the most important mutation, what she has already described at length, SF3B1 is a driver mutation. It is a mutation which is a hotspot mutation. Case 700E is the most common hotspot in this. I'll show you in the next slide. And in this, you have MDS with ring sideroblasts. And in the 2016 classification, how to diagnose RARS has been further refined. And you know that this is one of the best or the most treatable type of a MDS. You have a drug available in this called luspatercept, which is now in use in many centers. And the median duration to the evolution to AML is the maximum in this. You can look at the various hotspots that are seen in SF3B1 gene mutation in myeloid malignancies, including myelodysplasia. And case 700E is the most common, 55% of the patients, followed by case 666N and R. So the next most important, which is not a good mutation to have, is the U2AF1, which is the U2 complex auxiliary factor 1 gene, which is present in about 11% of the patients of myelodysplasia. These are also hotspots. And when you do the NGS analysis, either you can look for the whole gene or you can look for the hotspots. I'll come to that a little later. And this mutation gives the worst survival outcomes and has got an increased propensity to develop into AML. SRSF2 is also a serine arginine-rich splicing factor 2 gene, present in about 14% of patients with MDS, located in chromosome 17q25.2, that comprises of RNA recognition motifs for binding the RNA and the RS domain for binding other proteins. It is associated with increased in age, higher hemoglobin, and normal cytogenetics. But this is a mutation that is seen in about 1/5 of the patients of MDS. DNMT3A is very, very important. So this is a mutation that is an epigenetic mutation. And this involves the DNA methylation, which is transferring the methyl groups to specific CPG structures in the DNA. 11 to 13% of MDSs will have it. And the hotspot is R882 amino acid residue, and the overall survival is not so good. If you have this, you can see the Kaplan-Meier analysis and you can see the green plot, and you can say that it rapidly increases and then plateaus over the blue line. So if you have it, it's not such a good one. TET2 is very commonly found. This is 1011 translocation. Self-renewal and clonal expansion of hematopoietic stem cells are involved because of this gene. And in here, what happens is 5MC is converted to 5HMC, hydroxyform. And there's a loss of function mutation where the DNA methylation is impaired, DNA demethylation is impaired, and 25% of the patients will have this. So this is the commonest mutation to have in myelodysplasia. SLX1 is pretty bad, present in about 15 to 25% in different series. Worse prognosis and unfavorable survival outcomes in MDS. And EJH2 is also a histone modifying gene, occurs in about 5 to 8%. One of the last genes that I'm going to describe is the P53 gene mutation. This is a loss of function mutation seen in about 10% of the patients, and it is worse prognosis than MDS, even in post-HSCT patients. An increased risk of leukemic transformation is there if you have TP53 is mutated. And a monoallelic TP53 mutation could be seen where you'll have a VAP of variant allele frequency of more than 22%. And the hotspot is R175 and R248, correlates with increased risk to evolution to acute myeloid leukemia. So this is a summary slide. I'm not going into the detail I have already described. And this summarizes that there are some mutations which are seen more frequently in MDS. Clonal hematopoiesis, he has already touched upon. Age-related clonal hematopoiesis yesterday was discussed by Sonia. Clonal hematopoiesis of indeterminate potential also has been discussed by Rutvi. And here what you need to do is, when you do check the mutation, usually it is between 2 to 20%, and without any cytopenia or much of hematological changes, but you find a clonal population in the NGS analysis. So ICAS, CCAS, everything has been discussed. So I skip this slide. So the diagnostic criteria for CHIP molecularly is this, that there is an acquired mutation in a leukemia-associated gene, DNMT38882SLX1, at a VAF of more than 2% and less than 20%. And there should be absence of persistent peripheral blood cytopenia or a normal peripheral blood count. And there should be lack of evidence to suggest that the patient has MDS or other myeloid malignancies. So whether this chip is going to evolve into MDS is a $1 million question, unlike the MGUS, where almost 10 to 15% of the patients of MGUS will progress into multiple myeloma. So this is the clinical and molecular characteristic of ICAS, CHIP, and CCAS. She has showed this slide, so I would not spend much time. This is a publication in Cell 2020. It says about the incidence of molecular mutations and the dysplasia, the cytopenias, and the clonality. And it has said that most of the mutations that I have described, though 5, 6, are the main incriminating mutations. So prognostic implications of molecular alterations. This is a summary slide. You all know about the IPSS-R. You also have an IPSS-M, which rightly probably she has not alluded to, because this is a revision of this revised IPSS in a molecular manner where molecular mutations have been added to the IPSS-R. I'll show you in the next slide. You can see it here. You have all the characteristics of IPSS-R. In addition, you have the genetic mutation which scores. If you have SF3B1, that the best one to have is -1. Whereas if you have TP53, is plus 4.0. So you can calculate the score. It has been published in Journal of Hematology in 2022. So I'll skip this slide. This shows the same thing, what I have just said. Molecular targets are now available for therapeutics. Luspatercept is one of them. So what is the role of NGS in this? We have multiple modalities. You have Sanger sequencer to do monogenic genetic alterations. You have NGS where you can target them multiply. So NGS can identify at least one somatic mutation in more than 90% of the patients of MDS, what has already been told by my predecessor also. So to establish the diagnosis in MDS and to identify the clonal nature of this unclear cytopenia, NGS could help. Diagnosis of early MDS. Pivotal role of NGS is in the understanding of the pathobiology of the germline mutations. Sometimes you have RUNX1, DDX41, you have other genes which are present at germline, you may study them. It improves the prognostication. Like yesterday we discussed about isolated 5q minors. If you have associated TP53, lenalidomide doesn't work that well. So identification of potential therapeutic targets is gradually evolving. Monitoring and effectiveness of therapy, including post-LOST, can also be assessed by NGS. Technical validation and standardization of interpretation and reporting of NGS results is required, and most of the laboratories who have switched over to NGS are gradually refining themselves as to what to report, at what VF, what is VUS, what is not pathogenic. So these things, so we have to report in a tiered structure of report molecular mutations. So this is a 50 gene panel that we use in our lab. This has got 29 fusion driver genes, which is RNA based. And then we have 23 hotspots and 17 full genes. And you can see that most of the major mutations are covered. This includes for AMLs, for myeloproliferative neoplasms, as well as myelodysplastic syndrome. So one assay for all 3 myeloid malignancies. This improves the turnaround time because we include large number of cases. In our center, we do at least 12 samples in one run so that it becomes cost effective. So this is one of the reports where we have the missense mutation in exon 7 of the TP53 gene. And this is our result of 37 mutations that we have found only in myelodysplasia between 19 and 2022. This is at least one pathogenic mutation seen in 21, more than one pathogenic mutation in 13, and no mutations could be seen in 16. So these are the numbers. Majority of them are splicing factor mutations. DNMT3A is 21%. P53 is 9%. So this is the pie diagram to suggest what are the mutations that we have found. In 37 patients, this is the NGS lab of our center. And to conclude, molecular landscape of MDS is quite complex, as we have understood, due to high rate of genomic heterogeneity, affect diverse pathways, singularly or in combination. Approximately 90% patients of MDS will have some kind of mutation if you do molecular studies. 50% will have some chromosomal alterations. Germline mutations are quite rare, but not uncommon. So in the appropriate situation, particularly in situations of sibling transplantation, you must look for germline mutation in pediatric MDS. Integrating the mutational analysis into the IPSS will probably happen. The new WHO Blue Book is going to come out in 2023. So you will have a IPSS R type of a M type of a prognostic classification. They may call it WPSSM, because there are 2 groups working. One is the Peter Greenberg's group, and another one is the WHO group. And Dr. Neil Young knows the politics of these 2 groups. Next generation sequencing assays can be a valuable tool in the diagnosis of MDS, prognostication, and treatment decision-making, provided used in the appropriate setting without making it universal for all patients. So The science is evolving. The final word is not yet said. Standard of care is not yet defined. And I think we'll wait for that for another couple of years to say whether NGS is required, not required, when required. So with that, I end my talk. In case any questions, I would be happy to take a couple of them.